Welcome to Nasdaq Trade Talks. I'm Jill Malandrino, Global Markets Reporter at Nasdaq. Joining me is Dr. Raymond Tesi, President, CEO, and Acting Chief Medical Officer of Nasdaq-listed InmuneBio, a California biotech company working on COVID-19 treatment, starting phase 2 human trials. Dr. Tesi, it's great to have you with us. Welcome to Trade Talks.
Thank you, Jill. It's a pleasure to be here.
And let's start from the beginning with the initial course of treatment for COVID-19. What went wrong?
So I don't think so. First of all, I'm a doctor by training. I was a transplant surgeon in my previous life. So, I have a lot of empathy for those that were on the front line, and my sister is an ER physician. It's not that what went wrong is we didn't know anything. I mean, when this pandemic washed up in Seattle in February, we really thought this was influenza. We didn't really know what it was, and the disease was treated to the best of everybody's ability. And part of the problem was they overreacted to some of the pulmonary manifestations, the problems with the lungs, right? And often they made things worse. It's very clear that partly because the medical community has been communicating so well, and partly because of experience, hospitalizations aren't down, but ICU admissions and deaths are down dramatically. And that's just because everybody now has a much better idea what they're doing. So it's not that the patients got bad care in the beginning. They got, shall we say, uninformed care. So if you're getting sick now, the chances of you surviving is much better.
Right, and we certainly thank you and your sister in the medical community for that. That just proves that time and science and data does matter. We're seeing it unfold in real time. So let me ask you, what happens with, and I hope I'm pronouncing this correctly, with cytokine storm and COVID-19?
So one of the really remarkable things about COVID-19 is that only 20% of people that get infected get sick enough to come to the hospital. And when you show up at a hospital, it turns out that the amount of virus in your body is on the way down. It's actually decreasing because your immune system is winning the war. In other words, you're getting better, except for the fact that you've got this immune system that's so revved up, it's raising havoc with you. And so what gets revved up and out of control are these cytokines, and you get this cytokine storm going. So it's actually what's making you sick at this point is not the virus, but it's the response to the virus, the cytokine storm. So our therapies for patients that actually get sick enough to come to the hospital has to focus on controlling the problems associated with the cytokine storm.
So that sounds, it's like inflammation of your immune system, if I understand this correctly. So how does that affect the body?
So good question. So it's actually dysregulated inflammation. Immune cells, when they get excited and go on the attack, they produce these proteins called cytokines. And you've heard some of their names. They're interleukin-1, interleukin-6, and TNF. Those are the three that are important in the cytokine storm. And those cytokines are supposed to help the immune system kill the invader. Well, I already told you, they've already kind of killed the invader. And so what happens, they're kind of out of control, so they start hurting us. And the main thing they do is once they get outside of the blood vessels into the tissues, they start causing tissue damage. But one of the things that we believe that's a little unusual compared to many companies is we think the major problem with the cytokine storm is actually inflammation of the endothelial cells. Endothelial cells are the cells that line the blood vessels. And they're usually pretty inert. They kind of sit there, they're kind of fat and happy, and they're just watching the blood go by, and they're letting nutrients get into the tissues. But when they get inflamed by the cytokine storm, and it's TNF is what gets them inflamed, they start doing bad things. And one of the bad things they do is they start causing blood clots to form. And you may have heard a little bit of this, and it really actually started with the Broadway actor that ended up in the hospital and ended up having an amputation because of the blood clot. That caused the medical community to go, what's going on here? And we began to look at COVID and understand that these blood clots were coming out of nowhere, and they were a big part of the problem. They're a big part of the pulmonary problem, the renal problem, the heart problems, and the problems in the brain. So in fact, we are now convinced, and we're not alone, that the endothelial cell is the bad actor. That's going to be the villain when they write the book of the pandemic. And so one of the things that we do when we are targeting the cytokine storm with Quellar, which is our drug that neutralizes TNF, not only is TNF the master cytokine because it is the most important cytokine, it's the only cytokine that decreases the endothelial activation. And we hope to show that by decreasing that endothelial activation, patients don't get as sick, they don't have blood clots, they get out of the hospital faster, and they feel better.
So how will this clinical trial work, and where do they take place?
So the clinical trial has to be simple, because you can imagine a hospital when it's, these patients are coming in and they can get pretty busy. So you can't be complex. And the great thing about Quellar is it's an easy drug to give. You just give it as a single subcutaneous injection. It's like getting an insulin shot. It's still a shot, but it's very easy to get. It's like getting a vaccination.
A flu shot.
It's that simple. It's like getting a flu shot. Absolutely. So when the patient comes in, if they're having trouble breathing, and we can make some measurements, they signed informed consent. There's a big process to go to enroll them in the trial. And it's called a randomized trial. And the patient or the doc doesn't know what they're getting. And that's important to help us understand whether the thing really works. So the patient gets a shot. Half of the patients get Quellar. Half of the patients get salt water for all practical purposes. And then, 28 days later, we basically keep score. Now, obviously, above all, do no harm. It's not like these patients are being put at risk. Hopefully, instead of just getting the standard of care, they're getting better care in the Quellar arm. So hopefully we shorten that hospital stay. We prevent them from requiring respiratory support with ventilators or CPAP machines. We keep them out of the ICU. Now, one of the very funny frustrations with setting up clinical trials for COVID-19, and we're not alone here, is, as you know, the disease is kind of rolled around the country, right? It started in Washington State, then it ended up in New York and New Orleans. Then it hit Florida, then it rolled across the South into Texas, and now it's rolling up through the Midwest, including Minnesota, Wisconsin, and North Dakota. So when you're sitting here and say, okay, I'm going to do a clinical trial, I'm going to where the hotspots are, and we're opening sites in Florida and Tennessee and in the South, we're like, okay, we're in the hotspots. It takes about a month to open up a site. And then by the time you get there, the pandemic has rolled into Wisconsin, and you can't chase it. It's just hard to do. But the fact is, because of the way, as you know, hospitalizations are increasing again. They're increasing everywhere, but our trial will be primarily in the South, Texas and Florida, maybe a little bit in California. And it is going to focus on patients that are high risk. And what are high risk? The high risk players are the elderly, older than 65, patients with cardiovascular disease, patients with obesity, diabetes, Blacks, and Hispanics. So those are the patient populations which really suffer most from this disease. So trial's open, we're on our way, and we're hoping to make a big difference at the bedside, because at the end of the day, what really matters is, do patients get better? And if patients get better, we've done a good thing.
I certainly hope so, and we learned something from it as well, because this probably
Absolutely.
won't be the last one that we go through. But I have a couple more questions for you.
Sure.
What about other therapies like steroids, such as dexamethasone?
So I was a transplant surgeon in my previous life. I know a lot about some of these medicines. I've been giving some of these immunosuppressive drugs for a long time, and dexamethasone is a mixed drug. Okay, it is a potent anti-inflammatory drug, meaning it taps down the inflammation just like we're trying to do, but it's also immunosuppressive. And all of the data suggests that if patients who have been on steroids, which dexamethasone is, it's a corticosteroid, long-term have a higher risk when they get COVID-19. Now that's a little bit different than the question you asked. What you're saying, if someone comes in and they're sick, do I give them dexamethasone and hope that the anti-inflammatory effects, which we want, outweigh the immunosuppressive effects that we don't? And I have to say that the data are decidedly mixed. It definitely falls under the category that I like to call is might help, probably won't hurt, okay? Now, when you're a desperate physician at a bedside trying to take care of a patient, sometimes might help, won't hurt is kind of good enough, right? It's not the best place to be, but if that's the tool you have, you use it. I think ultimately dexamethasone use will decline. Kind of remember the hydroxychloroquine story?
Right.
That kind of same thing. Initially, we thought it might work, but it gradually disappeared. I think Dex will also do that because we're getting better drugs are coming to the table like ours. But we're still in clinical trials. It's not like I can go today and order dexamethasone for a patient. You can't do that with Quellar, right?
Right. So a therapeutic approach, is that a good approach to treating COVID-19? How does that compare to an antiviral or a vaccine? Is one to prevent it and one's to treat it?
So you've exactly hit it. There's actually 3 phases of the disease when it comes to therapy. Obviously, we're all waiting for the vaccine, which is prevention. We won't get back to normal until we get that vaccine, right? And golly, God, you and I, we're getting tired of this thing. But the bottom line is, until the vaccine is available and we get, more than half the people get vaccinated, we're going to be stuck doing what we're doing. So that's a preventive strategy. I think the more interesting thing is the antiviral strategy. I already mentioned that by the time you get to the hospital, your viral titer is on the way down. So in fact, you really don't need the antiviral therapy. The antiviral therapy should given to the patient the first day they hit a fever or the first day they cough. They should go, I just coughed. I just had a fever. I should go get a test. Ideally, in 15 minutes, you go, I'm COVID-19 positive. That's when to treat the patient with an antiviral, because at that point, their viral titer is on the way up. They're not sick yet. They got a little fever. They got like cold symptoms, right? By the time 7 days later, they're sick enough to go to the hospital. Remember, their viral titer is going down. They don't need antiviral therapy at that point. They need therapy to treat the cytokine storm. So I think in the future, what'll happen when testing gets better and faster and there's antivirals available, people will say, look, if you got a fever, got a cough, you vomited, right? The 3 major symptoms associated with COVID-19, go get a test. If it's positive, I'll give you antiviral. And that should decrease the deep. I'm willing to bet, look what's going on at the White House. All these patients are getting positive. None of them are really ending up in the hospital. That's because what happens, the medical staff at the White House says, ooh, you're sick. You're positive. Before you get sick, I'm going to treat you. And that way they never get sick. That's that if you're going to get the disease, you want to get it in the White House because you're going to get treatment before anybody else. You and I are stuck waiting until we get to the hospital, right? But the point I'm trying to make, I'm not being snarky about the White House. The point I'm making is that the earlier you treat a viral disease, the easier it is to prevent the patient from developing catastrophic medical complications.
All right, Doctor, appreciate all the insight. Thanks for joining us on Trade Talks.
Pleasure. Thank you for having me.
You got it. And thanks for joining me. I'm Jill Malandrino, Global Markets Reporter at Nasdaq.
Cheers. Thank you.